First, I will just go with that. So, jet ventilation, types, indication, advantages and disadvantages. So, initially itself, you first to say the principle, jet streams originating from high pressure sources are cut by pneumatic or electronically controlled flow interruption devices, and that generates a tidal volume, and that can be supplemented by entrainment of gases, the jet nozzle. So Venturi principle is involved in that. So that has to be mentioned in the beginning of the answer itself. So expiration, after you do the inspiration, jet ventilation mainly produces a inspiratory phase, and expiration is dependent on the passive lung and chest wall recoil, and other mechanisms that are involved in the distribution of gases are pendulum, describes the movement of gas between lung units and the different time constants. That is a property related to the product of compliance and resistance. And following inspiration, there is a redistribution of inspired gas from very fast filling units to slower filling units and augmenting gas exchange. So all the principles we can first mention, so that it need not be repeated again and again when you say that later. These points are repeated twice in your answer. That can be proven that they can explain the principles in the beginning itself. And another method is the convective streaming or Taylor dispersion, which occurs as a result of asymmetrical velocity profile of the inspired gas front as it moves through the bronchial tree. And molecules in the central zones where axial velocities are higher diffuse to lateral zones with lower axial velocities. And cardiogenic mixing describes how the beating heart exchanges gases. So these are all the mechanisms by which a simple gas which is pumped into the trachea, either through a bronchoscope or through directly, straight away is able to go down up to the alveoli and ventilate the patient. So all these mechanisms are involved in that, and bulk flow is another thing. So four mechanisms you have to remember. One is the Venturi principle, which augments or entraps the extra air and increases the supply. Second is the pendulum, which means gas flowing from one segment to other segment, and the convective streaming, where the gas going in a laminar fashion, as you should know that there is a central will be the velocity will be asymmetrical between center and periphery, and the third is the cardiogenic mixing principle, which beating heart causes the movement of the gases, and fourth is what is called the bulk flow, contribute to partially to gas exchange, leading to edge of the gas front may reach several proximal alveoli. So because of the large volume that goes, this bulk flow, cardiogenic mixing, convective streaming, and pendulum, and the Venturi principle. All these five are the main principles of jet ventilation. Then coming to the types, it can be high frequency or low frequency. Low frequency is usually applied as a hand triggered ventilators. The examples of that are the Sanders or Manujet ventilators, which are used usually in rigid bronchoscopy. I don't know how many of you had the experience to use it or seen that. So it is attached to the end of the bronchoscope with a clip. 18 gauge needle will be attached there, and you have a control switch on your or a toggle switch in the hand of the anesthetist. And when you press it, oxygen will go at a high pressure into the bronchoscope or into the trachea, and this will create a zone of negativity which will suck in the atmospheric air. And even if you give 100% oxygen, what is the percentage you will achieve when you use the jet ventilator? You are supposed to deliver 100% oxygen into the bronchoscope, but it will entrain atmospheric air and it will dilute it. So what is the ultimate percentage you will get? You don't know the answer, the homework, you try to find out.
Yes, sir.
The application is limited to short investigative procedures, laryngoscopy or bronchoscopy. It has also a important role to play in the management of difficult airway and cannot intubate by cricothyroidectomy formula. So these are the two indications for that. But high frequency jet ventilation, it requires a special equipment. You cannot just use it like a Sanders or Manu jet. And its commercial jet ventilators are available to deliver heated, humidified jets at 1 to 10 hertz. And it produces a continuous flow, and the continuous flow it produces is chopped into square wave pressure by high frequency flow interruption, which usually done by electrical solenoid valve. What is a solenoid valve? You don't have an idea, again another homework. And fluidic rotating cylinder valve. So this is another homework you can take. What is the fluidic principle? And driving pressure, frequency, inspiratory time, and composition of jet gases have to be adjusted when you are using high frequency jet ventilation. Third subpart of this question is indications for jet ventilation. It can be emergency, where it can be used for transtracheal cannula in life-saving measurements like can't intubate, can't ventilate situation. It can be used in elective procedures like transtracheal jet cannula used for direct laryngoscopy, vocal cord surgery, or preventive placement of cannula for, or even tracheal reconstructive surgery. It is used. And for ENT, it can be used for diagnostic laryngoscopy, and it will deliver small tidal volume, produces less vocal cord movement, while high pressure in which the narrow to deliver the required tidal volume. And there is no impedance. These jet ventilators can impede the surgical access less than the conventional ET tube, because there is no occupation by an ET tube. It makes the surgical approach easier. And the catheters are constructed from non-inflammable fluoroplastic material, providing advantage for use in laser surgery also by reducing the chance of airway fire. And in thoracic surgery, the passage of narrow catheter through the surgical field causes much less interference again without the standard W1 tube that is required. So high frequency jet ventilation is employed for pneumotomies or other lung surgeries also. And in tracheobronchial reconstruction, it is the main technique without it's called the tubeless anesthesia. So you use a very narrow catheter to provide relatively unobstructed access, and the circumference of trachea and bronchi can be extended and it can be aligned and featured easily. And the use of this in one lung ventilation also can be during ventilation also. It can augment the reduce the hypoxemia and improve the oxygenation. So the non-dependent lung is held slightly distended by minimizing the shunt and increasing the mean airway pressure, aiding perfusion. And it can be used in bronchopleural fistula and tracheobronchial fistula disruptions. Third indication is radiology, and it can provide motionless field, especially for radiologically guided procedures like radiofrequency ablation of liver tumors. And it minimizes the breathing related to liver motion by reducing it from 12 millimeters to 2 millimeters. So in a normal conventional respiration, the movement of liver will be very, very drastic. So it can be avoided. And radio frequency ablation of left atrium using this HFE is more stable, and left atrial environment with less radiation it can happen. And elimination of diaphragmatic exertion during extracorporeal shockwave lithotripsy. When they do the lithotripsy procedures for breaking the kidney stones, this can be very useful. And critical care can provide lung protective ventilation strategies with low tidal volumes to reduce the risk of overdistension and volume trauma, and it reduces the swings during ventilatory cycle. Advantages and disadvantages of these various approaches where you can be given supraglottic, transtracheal, or subglottic. That is, high frequency ventilation can be provided at the supraglottic level, or transtracheal level and subglottic level, and that provides a tubeless anesthesia technique or ventilatory technique. The transtracheal also tubeless, which can control the FiO2, and subglottic minimal increase in airway pressure, better control of FiO2, and airway ETCO2 monitoring also is possible in the subglottic. The disadvantages are it increases the rapid increase in airway pressure by the supraglottic technique, relies more on surgeon for adequate ventilation, and vocal cord movement slightly can happen, and no control of FiO2. And transtracheal, incomplete control of ventilation because you are producing a small catheter through that, and it is contraindicated in tight stenosis cases, and it is not possible to monitor the airway pressure or the EPC. And the subglottic, there will be a catheter, small catheter in the surgical field, which some surgeons may feel the hindrance because they feel that ventilation from above the glottis will allow them to have a clear view of the diameter of the trachea and the bronchi they want to reconstruct. And complications mainly barotrauma, and it can impair cardiac output, and right ventricular end systolic volume shows a direct relationship with ventricular frequency. As the intrathoracic pressure rises, what will happen? Venous return will get reduced. Right ventricular afterload also will increase due to compression of the pulmonary vasculature. So that will cause a strain on the right ventricle, and it will fail to cope with this increased afterload. Complete loss of cardiac output may happen. And exposure to dry gas without humidification for a long time, that will also spoil the mucociliary excavator and cause encrustation. And prolonged exposure can cause traumatic airway injury and tracheobronchitis, atelectasis, loss of ciliated epithelium, mucosal inflammation, etc., all because of the dry gas. And hypercapnia can happen because it only the expiration of carbon dioxide is mainly dependent on the passive recoil of the lung and chest wall. So CO2 elimination may not happen completely, and unless the tidal volume reaches. This is modulated by changing the driving pressure. The most effective way of to increase CO2 elimination is to increase the driving pressure and leaving the frequency unchanged. And large increases in driving pressure and frequency reduce CO2 elimination, as the expiratory time for exhaust gases also reduced. So it should be at the ideal rate so that you can eliminate the CO2. The complications because of the barotrauma, dry gas, and inside ventilation. So it can result in hypoxia, hypercapnia, and airway soiling of peripheries and secretion, vomitus, etc. So these are the points that you have to think about it. I think radio frequency for beginning is not here. Topic